Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prasad Halkarnikar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopulmonology, etc. With a very strong R&D support, we have developed many unique formulations, keeping patient benefit and clinical outcome in mind. Our endeavor is to develop products or formulations and combinations which will improve patient compliance and ultimately lead to a better clinical outcome. We have developed NSAID patches for pain, rivastigmine patches basically for improving patient compliance. At Frenza division in Hetero, gynecology, obstetrics, IVF is an important therapy for us. We market products for vaginal health like Feminora, Pellitra, etc. We have formulated and introduced a vaginal film containing lactic acid. In oral formulations, doctors, besides dydrogesterone and other products, we market Mylotin. Mylotin is a unique nutraceutical combination for PCOS management, containing myoinositol and D-chiroinositol in a ratio of 40:1, and chromium picolinate and melatonin, along with folic acid and vitamin D. Now, to speak more about PCOS and its management with nutraceuticals with myoinositol and D-chiroinositol, we have Dr. Prasad Halkarnikar with us today. Welcome, Dr. Prasad. Dr. Prasad Halkarnikar is MD Obstetrics and Gynecology. He practices at Sneha Hospital, Kolhapur. He is currently president of KOGS. His area of interest is infertility and vaginal surgeries. So, not taking much time, over to you, Dr. Prasad, for your inputs. Welcome once again.
Yes. Good afternoon. Thank you, Kandeparkar sir, for kind introduction. I am thankful to Hetero Pharma for giving me this opportunity. Then should I start screen sharing? Troubleshooting in PCOS. I have to start this. Hello.
So click on enter. Enter.
Okay. This is not moving.
Doctor, I'll do one thing. I will share the screen if you want.
Yes, okay. You can share.
Yeah, you can just log out. I mean, you can just close your presentation. I will share.
Yes.
Yeah, just give me 2 minutes.
Yes. You started it?
Yes.
Yes. PCOS is a complex disease. Around 50% women are diagnosed with PCOS, out of which 50 to 70% have hirsutism. 5 to 10% of women are of reproductive age group, and 30 to 75% of them are obese or overweight. And 50 to 70% of these women have insulin resistance. Next one. 1 in every 5 women in India suffers from PCOS. PCOS is one of the most prevalent endocrine system condition affecting women with reproductive age, also known as hyperandrogenic anovulation syndrome or Steen-Leventhal syndrome. In this condition, at least one ovary has an ovarian volume greater than 10 ml, and at least one ovary has an estimated 10 small cysts with diameters ranging from 2 to 9 millimeters. It is usually diagnosed when complications like hair loss, alopecia, acne, and infertility related problems develop that significantly reduce a patient's quality of life. Steen-Leventhal syndrome was described by Steen and Leventhal in 1935, which consists of hyperandrogenism, menstrual irregularity, and polycystic ovaries. In the symptom complex of PCOS, in reproductive women, there is irregular menstrual cycles, hirsutism, infertility, and pregnancy-related complications. Metabolically, there is insulin resistance, diabetes mellitus, and cardiovascular system-related complications. Also, it involves psychological problems, and there is anxiety, depression, mood swings, and reduced quality of life with poor self-esteem. Pathology of PCOS involves environmental toxins, genetic predisposition, gut dysbiosis. This slide is slide. No, you have gone ahead, madam. Come back. Next slide. It causes hormonal imbalance, hyperandrogenism, and hyperinsulinemia. In hormonal imbalance, the derangement of LH-FSH ratio with increased LH secretions and decreased FSH secretion. In hyperandrogenism, the testosterone levels are increased and serum hormone binding globulins are decreased. All these things lead to PCOS with clinical features like hirsutism and acne, reproductive features, and metabolic syndrome involving diabetes. According to Barre et al., the 4 key contributors to pathophysiological alterations in PCOS are due to high consumption of carbohydrates, hyperinsulinemia, hyperandrogenemia, and persistent low-grade inflammation. Next. Diagnostic criteria of PCOS were described in 1980 by NIH. It consists of only 2 criteria. One is clinical and or biochemical signs of hyperandrogenism and chronic anovulation. And there should be exclusion of other endocrinopathies. While these criteria were revised in 2003 by at Rotterdam, and it consists of 3 parameters, and third is the new parameter, that is polycystic ovarian morphology on ultrasonography. To diagnose PCOS, 2 out of these 3 criteria should be there with exclusion of other endocrinopathies. Third is the androgen excess PCOS criteria, where a clinical and or biochemical signs of androgenism is a compulsion, while one of the 2 criteria and exclusion of other endocrinopathy is enough. Next. Clinical evidence of hyperandrogenism includes hirsutism, acne, and androgenic alopecia, all of which related to androgens on pilosebaceous unit. Hirsutism is a growth of terminal coarse hairs on the face or body in male pattern. Hirsutism is the most obvious clinical sign of androgen excess and is an important feature of PCOS. Next. The prevalence of acne is 12 to 14% among white women with PCOS, but it is higher in Asian Indians and women of Mediterranean descent, approximately up to 25%. Next. Androgenic alopecia, describing scalp hair loss in women, also can result from hyperandrogenism and is a recognized but uncommon feature of PCOS. Less than 5% of women with PCOS complain of hair loss. Typically, the hair loss is limited to crown and does not involve the frontal hairline. Next. The normal intermenstrual interval ranges between 11 to 35 days, and menses that occur less or more often are an indication of ovulatory dysfunction. A majority of women with PCOS, approximately 60 to 85%, exhibit gross menstrual dysfunction. The most common abnormalities are oligomenorrhea and amenorrhea, and it is the most common symptom. For that, the woman consult a gynecologist. Next. PCOS takes its name from enlarged polycystic ovaries, so commonly observed in women with hyperandrogenic common anovulation. Polycystic ovaries typically exhibit increased size and stromal volume and an increased number of small follicles. The Rotterdam criteria consider only the total number of follicles requiring 12 or more, measuring 2 to 9 millimeter in diameter, and that should be mean of both ovaries. Next. The prevalence of polycystic ovaries is quite high among women with androgen excess, up to more than 80%. However, from 8 to 25% of normal women and even 14% of women using oral contraceptives also met the ultrasonographic criteria for polycystic ovaries. Moreover, polycystic ovaries are commonly observed during normal pubertal development and even in women with hypothalamic amenorrhea and hyperprolactinemia. In 2003, Rotterdam diagnostic criteria expanded the population of women that might be assigned to diagnosis of PCOS by approximately 50%, due entirely to the inclusion of polycystic ovaries ultrasonography as compared to the criteria earlier recommended by NICHD. Next. Increased serum LH concentration, low normal FSH levels, and increased FSH-LH ratio are typical of PCOS, but they are more so in lean PCOS than obese PCOS. In the past, an increased LH-FSH ratio more than 2 has been regarded as a marker of PCOS, but the ratio varies with assays used to measure the gonadotropin concentrations. Consequently, gonadotropin levels or ratios are not a reliable diagnostic criteria. They neither make nor exclude the diagnosis. Next. Next. The overall prevalence of insulin resistance among women with PCOS is between 50%. Previous. This is dyslipidemia is most common metabolic abnormality observed in women with PCOS. Nearly 70% have at least one borderline. Most women with PCOS and insulin resistance are young and have ample pancreatic beta cell reserve. Consequently, they are able to generate a compensatory hyperinsulinemia, allowing them to maintain normal glucose homeostasis, at least in the fasting state. Next. Next slide, madam. Dyslipidemia is most common metabolic abnormality. Previous slide, madam. Dyslipidemia. Hello.
One second.
Yes. Is it settled?
So can you see the screen now?
Yes, I can see.
Okay.
Nearly 70% have at least one borderline or elevated lipid levels. Insulin resistance and hyperinsulinemia are associated with decreased HDL cholesterol and elevated triglyceride levels. Some also have observed elevated LDL concentrations. Next. Evaluation of women with suspected polycystic syndrome includes TSH, serum TSH level estimation, serum prolactin estimation, 2-hour oral GTT test, and fasting lipid profile. Endometrial sampling is taken only in patients who are exposed to unopposed estrogen stimulation for long time. Serum testosterone is tested in moderate to severe hirsutism. Morning follicular phase 17-hydroxyprogesterone is done in women with pre or perimenarcheal onset of hirsutism, a family history of congenital adrenal hyperplasia, or high risk ethnicity. Overnight dexamethasone suppression test is done where there are signs or symptoms of hypercorticolism. Next. Infertility affects 40% women with PCOS. PCOS is most common cause of anovulatory infertility. Approximately 90 to 95% of anovulatory women presenting to infertility clinic have PCOS. In addition, spontaneous abortion occurs more frequently in PCOS, with incidence ranging from 42 to 73%. Inherent ovarian disorder showing reduced rate of conception despite therapy with clomiphene. Next. There is a list of investigation where serum testosterone, DHEAS levels, 17-hydroxyprogesterone levels, serum TSH, serum prolactin, serum FSH-LH, total estrogen levels, SHBG levels, lipid profile, AMH level, 2-hour OGTT, along with TVS showing necklace pattern of follicular arrangement is characteristic of PCOS. Next. Goal of treatment of PCOS is regulation of menstrual cycle, improvement in insulin sensitivity, reduction of weight, improvement of fertility, and decreasing androgen levels. Next. Management of PCOS. PCOS is a condition that spans the life of woman. Fetal programming may represent the beginning of a syndrome characterized by hyperandrogenism and insulin resistance, which can have a series of medical consequences in adulthood, and old age. Menstrual and fertility problems evolve into metabolic complications as age advances, with early diagnosis being crucial if the aforementioned sometimes fatal complications are to be avoided. A precise diagnosis is important, especially at extreme ends of the reproductive span. Lifestyle therapy tends to be the first step in PCOS management, especially when excess body weight is associated. Pharmacotherapy is frequently used to manage the most predominant manifestations in each age group, such as irregular menses and hirsutism in adolescents, fertility problem in adulthood, and metabolic problems and risk of cancer in old age. Next. Lifestyle modification is first line of therapy to improve fertility, for better reproductive outcome, and control of metabolic syndromes. Healthy lifestyle includes healthy eating and regular physical activity. Physical activity, it is important to avoid excess weight gain for all women with PCOS regardless of weight. In excess weight gain, obese women, aim is to reduce weight up to 5 to 10% over 6 months. In diet, there is no specific diet, and she has to continue a regular diet, but with general energy deficit of around 30%. For prevention of weight gain, regular exercise of around 150 minutes per week of moderate intensity or vigorous exercise of 75 minutes per week is sufficient. For weight loss, moderate intensity exercise is for more than 250 minutes per week, and vigorous exercise for 150 per minutes should be done. Behavior strategies should include goal setting, self-monitoring, and slower eating habits. Next. In pharmacotherapy, low androgen oral contraceptives that contain drospirenone or progestin-only pills or mini pills are used. An inositol supplement, myoinositol, inositol, or combination of two, which can help manage PCOS symptoms such as hirsutism, acne, and difficulty conceiving, etc. Metformin is next drug. Lipid lowering agents are used for women with lipid abnormalities. Next. Current treatment, there are gaps in management of PCOS as each woman is having different symptomatology and different requirements. In lean PCOS, only for correction of PCOS, we use the treatment. Where there is infertility is associated, correction of PCOS and ovulation should be undertaken. Obese PCOS, there is correction of PCOS and weight loss is the aim. While when there is insulin, hyperinsulinemia, correction of PCOS and increase in insulin sensitivity is required. In hormonal imbalance, correction of PCOS and hormonal cycle regulation is important. And none of the present therapies do all these things. Next. Then this new formulation is there, which contains active ingredients like Mi-to-DCI in 40:1 combination, chromium picolinate, melatonin, vitamin D3, and folic acid. Mi-DCI regulates menses, improves egg quality, restores ovulation. Chromium picolinate improves insulin sensitivity. Melatonin improves oocyte quality. Vitamin D3 improves ovulation, and folic acid improves oocyte quality. Myoinositol di chiroinositol. In PCOS study shows about 500-fold decrease in Mi levels in ovary. Follicular development is impaired owing to reduced Mi levels in the ovary. Combined dose of Mi and DCI is administered, which is found to be extremely beneficial in treatment of PCOS. Myoinositol has a substantial role in ovulation, while D-chiroinositol has a role in insulin resistance. So there is a medical rationale to administer these together. Thereby, the combined administration of Mi and DCI in physiological plasma ratio 40:1 is considered as the first-line approach to PCOS, and that also myoinositol in dose of 200 mg twice a day. Next. Management of PCOS women using myoinositol and folic acid. Introduction of use of 2000 mg myoinositol and 200 micrograms folic acid 2 times a day is a safe and promising tool in effective improvement of symptoms and infertility for patients with polycystic ovary. In addition, PCOS is one of the pathological factors involved in the failure of IVF cycles. Typically, PCOS patients suffer of poor quality oocyte patients and methods. There is no moderate. Myoinositol and DCI are two stereoisomers of inositol and insulin sensitizers. In human ovary, Mi is a second messenger of FSH and Mi mediates FSH signaling. DCI is an aromatic inhibitor. Thus, Mi-DCI ratio 40:1 allow a treatment of polycystic syndrome. Mi-DCI ratio were able to improve the regularity of menstrual cycle, acne score, the endocrine and metabolic parameters, and insulin resistance. Next. Chromium picolinate is combination of chromium and picolinate. Chromium is combined with picolinate in order to increase gut absorption. When given in PCOS, it reduces hyperinsulinemia and hyperandrogenemia. It acts by enhancing insulin signaling. It improves insulin sensitivity and facilitates fat loss. It is better tolerated than metformin. The combined action of both inositol and chromium picolate on insulin regulation will help treat the underlying cause in PCOS. Next. metformin versus chromium picolet in clomiphene citrate resistant PCOS. Overall chromium picolinate was better tolerated as compared to metformin. Nonetheless, it can replace the metformin in long-term studies. Use of metformin versus chromium picolet in management of polycystic ovarian syndrome. Chromium picolinate was better tolerated than metformin due to lower side effects. Next, is melatonin needed? Concentration of melatonin in pre-ovulatory follicle fluid is lower in women with PCOS. Melatonin supports nuclear maturation of oocyte in vitro. Melatonin administration may be useful in vitro fertilization strategy and improve clinical outcomes of PCOS. Therefore, melatonin may improve improvement of oocyte quality and increase pregnancy rates. Melatonin is a sleep-inducing hormone that lowers stress levels. Next, role of melatonin in polycystic ovary syndrome. Based on data included, it was found that the administration of melatonin can improve the oocyte and embryo quality in PCOS patients. It may have beneficial effect in correcting the hormonal alterations in PCOS patients. Next, melatonin effectively reduces microscopic symptoms of PCOS related infertility. Colpocytological examinations were carried out which revealed that melatonin administration increased the expression level of MT1 receptors, GDF9 and BMP15 in PCOS at protein and mRNA levels. It was determined that melatonin administration reduced the microscopic symptoms of PCOS. Melatonin was found to be effective via the MT1 receptor in pathogenesis of PCOS and it suppressed the transport pathway of GDF9 to granular cell in antral follicles. Next. Melatonin in clinical management of polycystic ovarian syndrome. Melatonin treatment led to improvement of ovarian functions, oocyte quality, metabolic and hormonal profiles in PCOS. Accumulating studies provide persuasive evidence in favor of conjecture that melatonin, due to its broad spectrum antioxidant property, may play a critical role in care and cure of this syndrome. Next. Folic acid helps manage infertility rooted in ovulation problems for both women and with or without PCOS. Vitamin D3 may play a key role in helping some women seeking treatment from PCOS-related infertility and get pregnant. Next. I would like to discuss few of my personal experiences with melatonin. I have one 19-year-old girl with hirsutism and irregular menses and acne. Initially, she was managed with OCPs, but when put on melatonin, there is improvement in her acne score. Her skin became smooth and her menses became regular and flow was increased. Another case is a infertile woman, 28 years old, with other hormonal parameters normal. On TVS, there were typical round this chain of small follicles. Initially, she was put on metformin, but there was no result. So after 2 to 3 cycles, I put her on melatonin. With 2 months treatment, there was improvement in this ovulation and single follicle development was achieved. And with letrozole, we could achieve pregnancy in that case. Next. Thank you.
Thank you so much, doctor, for sharing your experience and giving us insights in PCOS management. Doctor, 1-2 questions I have,
Yeah.
Like we said, there are different type of PCOS, obese type, lean type, or metabolic type, or menstrual illness type. In which type of PCOS would you specifically prefer this type of combination?
Usually obese patients
Obese.
which are resistant to our regular treatments, because this treatment has to be carried out for long periods and we have to do a lot of counseling to continue this drug.
How long you would generally prefer this combination?
Around 2 to 3 months.
In general, doctor, is the type of PCOS age or weight related?
PCOS, in my experience, PCOS is common in earlier stages, around 20 to 30 years.
Okay.
And after 30, 33 or 35, the PCOS severity reduces. And we
Okay.
get problem in getting the women pregnant.
Yeah. No, a lot is spoken about this ratio of myoinositol and dechiroinositol 40:1. In
Yeah.
your experience, this is the right ratio?
Yeah.
It's a
This is
physiological
right
ratio.
and it relates with the physiology of the human
Physiological.
body and
Correct.
gives better results.
Any adverse effect you have seen?
Yeah, routinely we face this substernal burning, hyperacidity.
Okay. Even after taking after food.
Yeah, even after taking foods. Our female patients are usually fuzzy. They always suffer from this acidity and all problems.
And how soon you see patient response?
After around 1 month.
After around 1 month. And a patient going for IVF, would it make sense to prescribe this type of product before IVF for a month or two?
Yes, definitely. It improves the oocyte quality and results of IVF, as well as the OHSS, which is a dreaded complication in IVF. We can control to some extent with this kind of treatment.
Okay. So it will make a definite sense, good clinical sense too. And how common is gut dysbiosis in PCOS?
Nowadays, gut dysbiosis is coming up very
Exactly.
and there are lot many papers.
Articles,
that
yes,
if
there are
you
a lot.
can treat dysbiosis, you can cure lot many this kind of PCOS and other metabolic anomalies.
The gut dysbiosis, in the sense it would be a plain lactic acid type of formulation, which will take it. Thank you so much, doctor. Thank you for your insights. It was wonderful having you here and taking time to share your clinical experience. I thank all the participants who took time from their busy schedule and commitments and attended the webinar. Thank you, marketing team Hitro, for conceptualizing and organizing this webinar. As you all will agree with me, this type of program requires expert coordination. Without our support from field staff, it would have been impossible. Thank you, Hitro field personnel, for super coordination. Last but not the least, thank you, IT team Hitro, for your support and guidance in all technology-related matter. Once again, I thank all of you for attending this webinar and making it a success. Signing off and wishing you a very pleasant evening. Thank you, Doctor, once again.
Thank you.